So welcome to everyone that are with us today. Thank you so much for coming and for joining these NeuroTalks. As you know, we have today Professor Rodesch, that I know for many years and has been an inspiration for me. And it's an honor to have him today with us, talking about something that is very, very important, I think. It is complications in neuroradiology. Complications we all have, and I think we need to understand which complications are we having, and understand why are we having, and why are they happening. So, Professor, thank you so much for joining us, and welcome to NeuroTalks.
Thank you very much to everyone. Thank you for joining, and thank you, Thiago, for having thought about me to participate to this evening discussion. Yeah, indeed, when we discussed about the topic that we could eventually discuss today, I thought that we could eventually speak about complications. Don't take this as a guideline or gamut of all complications that you can experience. What I wanted to share, it's some kind of personal reflection on the types of complication that you can have. And I have begun to think about that, coming from the pediatric activity. And you will see that many of these pediatric concepts can be applied later on also to the adult concept. And as you can see from these pictures here, which represent the famous picture by Edvard Munch, the famous painter, Norwegian painter, representing the Scream. Munch painted, in fact, 5 different versions of the Scream, in lithography, in oil painting, etc., etc. And there are also surprisingly 5 different types of complications in the pediatric population, which can once again be extended to the adult population itself. And I have tried to regroup these complications in 5 different categories. Those that I have called the technical ones, related to a poor technique at one moment, which corresponds to anatomical complication. You will have tactical complications or strategical complications. And these strategical complications will induce neurocognitive complications in the evolution of the child's development. Then as a third point, you have what I've called the analytical complications, which means complications related to a poor analysis or poor understanding of the malformation itself. The most easy one to understand are the thrombotic ones, which means that you occlude the malformation, that there is an extensive thrombosis of the vasculature, mainly on the venous side afterwards, that creates problems that have to be recognized, can be easily treated by anticoagulation. And then finally, what I have called these emotional complications, and I will tell you a little bit more about that later. So to begin with the technical complication, you can see them if you manipulate poorly a microcatheter or a guide, and you create some vessel rupture. I will show you an example about that. It can also occur if you use liquid emboli that you have to dilute or concentrate. And if you do an erroneous dilution of the liquid emboli, mainly if you use glue, as you see here in pediatric vein of Galen malformations, to occlude this high flow fistula. If you erroneously dilute the glue, you can have distal migration of the glue itself. And this is why it is very important in these situations to try to find precisely a proper position of the microcatheter in front of the high flow shunt in order to avoid this distal migration. And If you dilute the glue too much, it will flow away. If you concentrate it too much, or if you deposit poorly the glue, you will create a proximal occlusion and secondary angiogenesis. And of course, what happens not so infrequently with onyx, and in my practice rather rarely with glue, it's the left the catheter in place because you stuck the catheter, it's glued in place, onyx in place, and you cannot retrieve it properly. I have to confess that nowadays with the microcatheters that exist that are very hydrophilic, and the way we try to inject this glue, this has not happened since for the last time, I think 9 years ago or something like that. And this is one of these examples, one of these catastrophic examples where the technical complication has occurred, where the poor deposition of glue has occurred. You see very well this neonate was in acute heart failure. Initially, there were many high flow shunts that were vascularized by all choroidal types of feeders, ending into the huge vein of Galen and draining into the torcular and both transverse sinuses. Actually, what happened is this. We put the catheter, or I put it, because I was responsible for that. I put the catheter perhaps too far inside of the vessel and not rather close to or close enough to a vessel wall. Theoretically, if you use such a pure glue, you have to use it so that the tip of the catheter is against the vessel wall, stuck to the vessel wall so that the glue does not escape too far. And this has to be made in front of a loop, of a curve of the vessel. Maybe I was too close in this situation, and despite the fact that the glue was highly concentrated and pure glue, you could see that this glue escaped too far and occluded the transverse sinus and the torcular. Associated to that, there was an escape of glue inside of the lungs, and the child passed away on the angio table. So in order to try to change this eventually, you have to think about eventually faster injection of glue, and especially also try to perhaps better position the microcatheter inside of the vessel, having the tip once again close to the vessel wall in front of a vascular curve, and inject then rapidly the glue in order to try to fix properly the glue inside of this vessel. So this is one of the problems that, from a technical problems that have to occur. So it takes sometimes much more time to find the proper position of the tip of the catheter than to inject the pure glue in this pediatric population with vein of Galen malformation. If you occlude the vessel too proximally, this is what happens. This is an HHT child presenting with seizures, had bled previously also from this macrofistula on the posterior posterior frontal area. You see very well that there's a high flow fistula with multiple shunts, multiple vessels ending into the pouch itself. And in this situation, the glue was, of course, far from the loop, close to a vessel wall, but perhaps here too proximal, because the glue solidified polymerizes inside of the vessel and poorly penetrated inside of the pouch itself. And you know very well that if you want to occlude such a high flow macrofistula, you have to make some kind of mushroom inside of the pouch, occluding the shunt, penetrating in a mushroom aspect inside of the pouch in order to occlude it. This mushroom aspect was not very well performed here. So we remain with a proximal situation. And after embolization, you could see that the lesion was not so badly disconnected. However, because we did not hit the bullseye, this is what happened. On the control several months later, this angiogenesis that was already around the lesion has developed because of the ischemia induced by the proximal occlusion. And this ischemia and this angiogenesis have recreated now a wholly brand new nidus type lesion draining inside of the same venous ectasia, which will then have much more difficulties to be managed because you are dealing with very small angiogenetic vessels. So you see that either poor deposition, either proximally or distally, can create problems of this type in actually any type of lesion. And this would also occur in an adult population, even if you don't go with a fistula. Angiogenesis might very well recruit or rebuild again some new vessels and reconstruct a nidus, even in brain AVMs. Rupture of the vessel, this is one of the things that might occur. This is a deep-seated lesion in a young boy that presented with progressive hemiparesis that we have embolized several times. We have stabilized the poor development of the child. He has stabilized the deficit. And this is the architecture of the lesion. You see very well the lesion is located inside of the lenticular body, partly into the internal capsule and inside of the thalamus. So I show you here some of the vessels that vascularize this lesion. Very small, tortuous, fragile vessels, venous ectasias draining into the vein of Galen. And while we were actually manipulating a microcatheter inside of one of these vessels, wanting to pass one of these distal loops, I tried to use a microguide, and the microguide perforated the vessel and created then this hemorrhage. This is leakage of the of contrast outside of the vessel. In this situation, there is no doubt you have to occlude, you have to seal, you have to glue very fast the rupture point, because if not, you will create an hemorrhage. So this is what I have done. Retrieve a little bit the microcatheter and inject and glue in order to seal the rupture. You see very well here the rupture points inside of the vessel. Thanks God, in this situation, everything went fine, and the patient woke up without any further deficit. But it can bring to catastrophe if you manipulate poorly the situation. So this is, once again, what I wanted to show you from the technical complication possibilities. There are certainly many more. I wanted to show you only some of these stuff. Tactical complications. The tactical complication mean that you have chosen the wrong moment to embolize the lesion. And in pediatric population, this means that you take a wrong decision for the therapeutic moment. So you miss the optimal therapeutic window that Pierre Lajonias has emphasized so often, or you misrecognize the disease, the architecture of the disease, or you don't know and you don't recognize precisely the natural history that belongs to this disease. And then you create a problem because you fail to obtain a normal neurocognitive development or a normal brain maturation process. And having in the pediatric population such a problem where the child will not develop properly represents a complication and certainly a therapeutic failure. And this is one of these examples of the child that was coming from abroad, that was sent to us, but too late. This child developed macrocrania and had progressively neurocognitive misdevelopment. And this is the CT that was initially performed and the MR that were initially performed. Obviously, there is a pouch that looks next to the transverse sinus. And because it was considered to be a dural fistula by the referring team from this foreign country, it was said, oh, the child is an infant, the lesion is outside the brain, you don't need to touch it now, we wait. It's too dangerous, it's too difficult to embolize the child in an infant age. So the parents accepted that, but the child progressively worsened. And the parents showed me when they came to us afterwards that they had sent regularly emails to the referring doctors and saying, well, the child is going to be hemiparetic. And then the child is going to be tetraparetic. And then the child is going to have swallowing disorders. And then the child fell into coma or semi-comatose state. And this is just because the lesion has continued to evolve. And when you look on the child, there was effectively some macrocrania. There were some dilated veins on the face. And the lesion itself corresponded indeed to a dural fistula with some ectasia on the transverse sinus. But it was a very dangerous lesion, despite it was outside the brain, because this lesion here, vascularized by a single mastoid artery, was draining retrogradely into many cortical veins, including the deep venous system and the superior sagittal sinus. So there was this congestion of the brain and of the posterior fossa because of the flow, pathological flow related to the malformation. And all this created some venous ischemia in the level of the brain. So it was not too difficult, actually, from a therapeutic point of view, from a just technical point of view, to occlude with a drop of glue the shunt itself and occlude the lesion. Coming from a situation where you had finally under controls the cure of the lesion, and you see here the occipital artery being cured. But the venous system, okay, you see very well, the venous system recovered, but it was too late. It was too late because there were some calcifications corresponding to the chronic venous ischemia of these situations. Oops, I lost my mouse. Hold on a second. Okay, here again. So there is this chronic venous ischemia has created these calcifications, and you see very well the suffering of the white matter of the brain. And this child, despite having had a very simple lesion, remains now for many years severely encephalopathic. So this is not a technical complication because the technique was well performed. It was just a poor strategy, a poor analysis of the lesion because we did not recognize properly the proper moment where you had to embolize this shunt. And this is another problem. I was personally involved into that one because this is a case we did in Stockholm with Michael Söderman. Again, a dural sinus malformation, okay, where you had all these ectasias on the sinuses. And there was a venous drainage going into the basal vein of Rosenthal. And of course, we wanted to suppress this venous drainage here. So this is the lesion. These are many of the feeders that were vascularizing the shunt. So we disconnected quite nicely, I think, the fistula with glue penetration inside of the shunt itself. You see very well also here. Look at the filling of the sinus before, look at the filling of the sinus afterwards. So we saw that we maintained a rather good reduction of the flow. However, there was always this drainage into the straight sinus that was already existing here. You see this is the basal vein of Rosenthal. And every time we suppressed the flow and the three sessions of embolization, we suppressed the flow. And there was some less filling of the transverse sinus, and we thought that it would be okay. But even after proper embolization, you always had this reflux into the deep venous drainage, deep venous system. So in this situation, despite the fact at one moment that the lesion could be cured in totality by endovascular treatment, the child remained, because of the drainage of this basal vein of Rosenthal, because of the venous congestion, because of the venous ischemia, also here severely encephalopathic. This is why I show this case, because I have missed here the proper moment to suppress this deep venous drainage. And this is why nowadays, when I have a child or a baby child with the same kind of problem, this is another dural sinus malformation, a child coming from the road, you see that he had some visual disturbances, also macrocrania, this is the lesion, and he had from the very beginning on this straight sinus reflux in this situation. So this is why, looking at the angiogram, you see this reflux, you see the congestion of the veins. I decide now to coil and suppress as fast as possible, or rapidly as possible, the reflux. So in this situation, I don't try to work too much on the sinus malformation. I go into the straight sinus, I coil the straight sinus, and afterwards you can then glue the remaining part of the malformation, have these results, and you obtain normal development of this child who is progressing very nicely. Forget about the lymphangioma that he has on the upper lid here. Okay. So we have technical, you have tactical or strategical, because you have not found the proper moment when to embolize this, and then the analytical complications. Analytical complication is what I've summarized under this term, because there is a poor analysis of the architecture and a mistake in the analysis of the lesion. And this can bring to catastrophe sometimes too. This is one of these problems. This is a baby girl who presents with a vein of Galen malformation. This is, you see the different MRs, and this is the angiogram. This is a choroidal form with many vessels entering the choroid fissure, running inside of the vein. Some vessels run at the posterior part of the tectal plate, okay, and feed some fistula here. And there was a big fistula at that level here. And I considered that because the vein here was large, or what I considered to be an artery actually, there was some kind of stenosis here because of the tentorial edge. And I thought that this would compress eventually this, and the fistula was actually here. So we did one shot of glue. This is first session. We embolized 2 high flow feeders at the posterior surface of the quadrigeminal plate. This was a rather good result. You see that the shunt has reduced. And for the second session, I was remaining with this situation. I said, okay, this is a huge high flow shunt. So the fistula goes into the mural aspect of the vein of Galen. So let's go to occlude that. And I thought that all this was in fact some collateral circulation running around the tectal plate and going to the distality of the artery before reaching the pouch. So this is what we found. This is the cast of glue. Cast of glue was very nicely performed. Okay, you see very well. You go into that part, you go into a little bit mushroom inside of the stuff. And this is the control. The control, if you remember well what happened previously, you had all this circulation here that I consider to be collateral circulation behind the tectal plate, has immediately disappeared. And as far as the choroidal vessels coming from the posterior cerebral artery, we had this disconnection also very nicely. And I thought, well, okay, the child is cured. We had stagnation in some of these arteries, and I said everything we modeled properly. However, this is what occurred. The child had an acute bleed several hours later with a progression inside of the brain stem, and the child had severe neurological disturbances. And finally, looking several times at these angiographic pictures, I finally found a solution of this mistake made, because the fistula was not here. The fistula was there. And all this is a choroidal vein ending inside of the pouch, and not a choroidal artery ending inside of the pouch. So what I have achieved is occluding a vein of a malformation located here and vascularized by collateral vessel coming from the ipsilateral and from the contralateral side. And this is explainable because in choroidal vein of Galen malformation, at the very embryological stage, the medial vein of the prosencephalon does not drain any deep venous system, but exclusively choroidal veins. And after maturation, it attracts the deep venous system. But in neonates or infants with vein of Galen, because the anatomy is frozen at an embryological stage, this pouch might drain choroidal veins. And this is the fistula that was located on the choroidal veins and not on the vein of Galen. So you see, poor analysis of the lesion can bring definitely to catastrophe. Thrombotic complications, rather easy to understand, rather easy to treat if you recognize them properly. This is a young boy also with macrocrania. You see very well these dilated facial veins. And he had a very peculiar lesion where I saw that initially on MR, I considered that this was some kind of high flow fistula, PL type at the cerebellar aspect. But angiography proved that it was not the case. It was a dural sinus malformation on the tentorial sinus. It was vascularized by all ipsilateral and contralateral feeders coming from the dura, but also PL feeders coming from the posterior cerebral artery and superior cerebellar artery, as you can see here. Well, actually, so we deposited glue inside of the various feeders for many sessions, and we reached cure of the malformation. But this cure of the malformation induced also thrombosis of all the cerebellar veins and posterior fossa veins that were draining also inside of this huge pouch and that were not clearly visible during the first aspect of embolization. As this child progressively worsened because of the venous sludge and the thrombosis of the veins of the brain stem of the posterior fossa draining into them. So we put the patient, when we thought about this thrombosis and we could visualize the effects of the thrombosis on the brain stem and on the cerebellum, we put the patient under high doses of anticoagulation, which helped actually to reduce the problem, to solve the problem, and to have a normal child growing up secondarily with no deficit at all. But here, this thrombosis has to be thought about. And as soon, especially in the pediatric population, as soon as you have one of these child that becomes more, especially in the neonate population or infant population, that becomes more grumpy, a little bit more sleepy, doesn't react properly, you have to think about this thrombosis, rapidly perform MR in order to see how it is, and eventually propose anticoagulation, even if there are some hematomas, because this is the hematoma of the thrombophlebitis that will not worsen by the other situation. This is another case. You see that this thrombosis might occur not only after glue, okay, but only also after coils. This is a vein of Galen, very high flow. You see very well the size of the vessel, nearly as big as the carotid artery. And there was obviously in this situation no glue to manage the situation because the flow was so high, and I feared to lose glue and not be able to occlude properly the choroidal artery in this situation. So I decided to coil it. So the coil went well, but obviously because you suppress the flow, all the exits do not receive the high flow blood anymore, and everything thromboses then rather rapidly after the occlusion of the shunt. So usually 24, 48 hours later, child becomes a bit more grumpy, less reactive, has headaches, and you need then to perform a control imaging in order to check for the proposed anticoagulation. And in this situation, everything resolves rather rapidly, but you have to keep the anticoagulation for several weeks usually. Actually, this is also a HAZA1 mutation, as you can see here, with the typical dots of the capillary malformation at the level of the skin. And then this is the worst, one of the nails of my coffin. This is one of the worst complications that I had, and that I call emotional complications. Why emotional complication? Well, this is because I had lost objectivity and critical thinking in such a case. This child was sent to me from abroad, and I was very moved by this child when she came to me, because she had this facial malformation, and from a neurological point of view, she was nearly blind. And I was very, very moved when every time I saw this young girl, this young child in her bed in the hospital, trying to look for a teddy bear by grasping on the bed without looking properly because of the visual problems. So I had no empathy anymore in this situation, neither in the child nor in the parents. And I lost some objective thinking in this situation. And I find it very interesting that one of the greatest psychologists gave some explanation about that. When he said in empathy with a patient, one can feel pain or happiness without ever forgetting that it is the patient's experience or perception. And if you lose that last condition of forgetting that it is the patient and not you, then it is not more empathy, but identification. And this is also as an echo to what Walt Whitman, famous American poet, said: I don't ask the injured person how she feels, I become myself the injured person. And this is why losing once again some objective thinking, you begin to think erroneously. And this was a terrible lesion, actually, because you see very well from the initial MR, angio-MR to OCT to the progressive aspect of the lesion. This lesion, this girl had indeed dural fistula of the skull base, multiple shunts. It's a typical juvenile type of lesions with multiple shunts, and also secondary creation of PL shunts, from which she bled, actually, also. And so we took her several times, and we embolized the dural fistula with huge penetration of glue inside of the venous lake on the skull base. And we also embolized the PL shunt that had been newly created and that had bled. And we left her with this nearly total cure of the malformation. I was quite happy about that. But at that moment, I was mistaken, because I was, at that moment, I should have stopped. But I always thought about that poor child grasping for a teddy bear, and the parents always asking about the facial malformation. Saying, what's going on with the face? Can you do something for the facial malformation? And at that moment, I took the decision, although the procedure was finished, from the brain point of view, I took the decision to do something for the maxillofacial lesion. And as we do it for small size lesion of the scalp, where you have one single draining vein, you can puncture the draining vein with pure glue and have the cast of glue occluding the venous exit, and you resolve all the problem. This is what I did. I punctured the main vein of this huge maxillofacial area. And I injected glue. But the flow was so high in this situation that some droplets flew out. So I decided to stop and to compress the exit. And then I continued to inject the glue. And the glue still continued to flow out because my compression was not firm enough or strong enough. So while I was injecting, I compressed more. And while I was compressing more, the head of the child turned suddenly, and I had my fingers below the X-ray. And as a stupid reflex, when I saw my fingers in the X-ray, I retrieved my hand. Okay, this is the glue, this is my hand. And obviously, as soon as I retrieved my hand, all the glue flew out from the vein because of the high flow, which was absolutely not mastered, flew in the lungs, and the child passed away on the angio table. Emotional complication, because my emotions at that moment were higher than the good, critical, medical thinking. So, in conclusions, what I wanted to share with you, and this is from pediatrics, can be applied strictly also to adults. First of all, complications have nearly always a human origin. If you have a complication, one should go and look regularly, although it's painful, go and look regularly to the pictures and try to find the explanation for this. You remember the baby girl with the vein of Galen malformation where I missed this fistula on the choroidal vein. Initially, I did not understand what was happening, and no one understood really what was happening. And it is after days and days where I ongoingly reviewed, suddenly I thought, well, and if this would be the problem? And it was indeed that. You have to force yourself to look till you find an explanation. So avoiding complication is a fight not only against the disease, but also a fight of the interventional radiologist against himself. And this is by Eugène Delacroix, the fight of Jacob against the angel. And this is what we have to do. We have to ongoingly fight against ourselves, to try to be as best as possible. So pediatric interventional radiology is a certainly demanding and rewarding specialty because it's very, very fascinating field of of interventional radiology. But it's also a school for humility. You should not forget that we can make mistakes. And as Tony Greitz said, Tony Greitz was, if you don't know him, one of the former heads of neuroradiology in Karolinska, where he said that in heroic procedures, the hero is always the patient and never the doctor. So there is a need also for personal ongoing improvement, not only in technical, but also in neuroscientific knowledge. We have to understand exactly what kind of disease we are treating, how it acts, what is the physiopathology, what are the microvasculature surrounding it in order to avoid any of these problems. It's not only because you have, as Alex Ben said, it's not because you have a hammer that everything looks like a nail. It's not because you have glue of onyx that everything should be treated that way, the same way. I'm personally always fighting because when I hear people say, onyx is the best treatment for dural fistulae. I'm not saying that onyx is a wrong material. This is not true. But if you use onyx on a skull-based lesion in an ascending pharyngeal artery that gives rise to all vasculature of the cranial nerves, you should not be surprised that you get a problem at one moment if you don't push properly your onyx in this situation. And this does also occur with glue. So all this neuroscientific knowledge has to be taken into consideration. So I hope you understand also that pediatric interventional radiology is not a technical specialty. It's not a miniaturized technical specialty, but it's also a clinical specialty in these situations. And you have to keep attention about that. And this clinical specialty grows properly and develops properly if you have a strong correlation with neuropediatricians, with pediatric neurosurgeons, with ICU physicians, etc., etc. So we are coming from the pediatrics, but children will become adults at one moment. And I think personally that these categories of analytical, technical, strategical, thrombotic, and emotional complications do play a role in any type of endovascular procedure management. This is what I wanted to share with you tonight.
Well, Professor, thank you so much for your brilliant explanation and presentation. One of our colleagues is saying that that's a présentation d'autre niveau, and I completely agree. Thank you for sharing your complex cases.
Tell him that his mother always told him not to lie. It's okay.
I'm sure it's not. But thank you for sharing your complex, very complex cases that you have been treating for so many years, and also for sharing your complications, because it's very easy if we get into an audience and just show what we are doing very well, that we all have very good cases, but showing your complications with showing our complications, and with this attitude of recognizing that we are the first one doing them. That's really brilliant. Thank you so much for that.
Thank you to you. Thank you to you for having asked me to join you tonight. It's a great pleasure and honor for me.
Thank you. I was just thinking that in a pediatric population, I think I guess because I don't do pediatric. I think that just some of us should do pediatrics, as it's so complex and also rare.
Jago, I interrupt you. I'm sorry to interrupt you. It's okay. I mean, if there is a point that could be interesting in this presentation is the way of analyzing the stuff. And as I told you, these problems occur also in adults. Perhaps not in the same way, but if you misrecognize a lesion, misrecognize or misanalyze a vascular malformation, if you don't recognize where the artery ends and when the vein begins, if you make a technical problem with a guide and a microcatheter and you don't know exactly where how to handle it, if there are some adult patients who have HHT, big fistulae, and if you don't use properly the glue or your coils inside of the situation, you can create. So what I've said here for pediatrics can be applied also strictly to adults.
Yeah, definitely. And also the candor of for ourselves and for everyone else, not being ashamed of sharing our complications and saying, well, that's wrong. I've missed this artery or I've done something wrong. Well, but this is part of the game, and this is what is not part of the game is complete every day start trying to hide something that we are not probably comfortable with, or because we don't know how to do and try to hide that. No, what we need to know and to do, and I completely agree. We need to know the anatomy, we need to know the physiology, the pathophysiology, and the catheters, and also we need to have time for reflection. And I think that exactly what you have been doing, and what you demonstrated clearly in that vein of Galen malformation of the choroidal one. I don't want to take your time and much more. I would just like to ask you, in terms of consenting the patients, of course, you are doing consenting of the parents. I guess there are tremendous and difficult decisions that need to be taken. And can you share with us a bit more of your experience consenting patients for another life, not for their own?
I think obtaining a patient's consent is always best obtained if you are from the very beginning on as honest as possible.
Yeah.
The problem with pediatric interventions is that you treat usually innocent patients that have not asked anything. It's the patient decision. So if the parent's decision to let that child be treated. So if you have a complication, it becomes a problem of guiltiness, because the parents might say, why have I let my child be treated?
Yeah.
So I think that from the very beginning on in this situation, being as honest as possible, explaining the different risks that exist in such a situation, allows the parents to take the decision properly. You have to describe the possibilities that might exist, the possibilities that might occur, the risks that might occur. And usually, if the patient or for adults, or even if the parents feel that you are honest with them, they will accept to give their consent for treatment.
And also will accept the complication.
Yeah, sure. Even if you have a complication, if you look at the patient, eyes in eyes, adults or for the parents, and you tell them honestly, I have fucked off this problem. There is a problem. The problem has occurred. People will accept it.
Yeah.
although it's painful, although it's terrible, although it's a drama, people will accept it much better than if they feel that you lie or if you try to hide something.
Yeah.
In this emotional complication that I had with this child, I was absolutely devastated by what happened. I was devastated because I had induced this problem. And I had made this mistake. I was devastated because I had to tell it to the parents. We were all devastated in my office here when I said that to them. And I was even more devastated when months later, I met them at a conference that I gave in the foreign country where the child was coming from. And the parents wanted to see me. And we had a discussion for 1 hour. And the parents thanked me for what I have done. Because I have tried to save their child while in the referring country, no one wanted to treat it. And this is even worse.
Yeah. Mm-hmm. Yeah, yes, it is. Well, Professor, I have a more like a practical question for you that is coming from Dr. Amit, and he's asking how much anticoagulation are you using after embolization of a high flow lesion, and for how long are you doing?
For how long? It's very difficult. It's very difficult to answer. We usually give, depending on the weight of the child and the age of the child, it's a dose of low molecular heparin, curative dose. So I cannot give you the dose by heart. Curative dose, low molecular heparin for at least 2 or 3 weeks.
Okay.
And then you stop. You make a therapeutic window. If the child tolerates it well, the stopping of the treatment, it's okay. Sometimes you see that the child begins to have again a grumpy state, or begins again to have headaches. Then you redo some anticoagulation. We have had vein of Galen malformation with thrombosis. Actually the child that I showed you that needed anticoagulation for 2 months. So usually we begin with high doses, low molecular heparin, curative doses, managed by the anesthesiologist and the neuropediatrician. You stop after 2 or 3 weeks and you see what happens. If it is not sufficient, you do an MR, you do a control, clinical control, MR control. If the clot is solved, it's okay. If the child is doing well, it's okay. If there is still thrombosis, if you have the impression that there is still some flow that doesn't flow, blood that doesn't flow correctly, still some sludge phenomena, and the child is not perfect from a clinical point of view, reintroduce anticoagulation.
Okay. Well, Professor, thank you so much. Many people are thanking you for this brilliant presentation, so I make my words their own as well, and I would like to thank you as well. And I know that you have commitments now, so I'm not taking more time. And I hope you can join us again in the future.
It would be a great pleasure.
Another NeuroTalks. Thank you so much, Professor.
Thank you to you. Thank you to all of you. And Thiago, thank you very much for having asked to participate tonight.
It's my pleasure. Thank you.
Enjoy your evening. Bye-bye. Thank you.
And you. Bye-bye.
Bye-bye.
Thank you all.